Yes, sir.
Yeah. So after a very lucid demonstration by Dr. Satish of mitral valve, uh, I'll go into the tricuspid valve, and imaging of the tricuspid valve by echo is difficult. Why? Because there is a lot of literature, a lot of textbook is telling the certain things, but no one is conclusive. Second cause is that majority of the time we do echo is spent on the mitral valve. Only 20% time is only spent on the tricuspid valve. That's why it has not developed so far. Anyway, normal tricuspid valve function depends on the interaction between the fibrous annulus, leaflet, papillary muscle, chordae tendineae, adjacent right atrial and right ventricular myocardium. So any congenital acquired disorder of these individual component of the tricuspid valve complex will result in valve incompetence or stenosis. The tricuspid valve anatomy shows a greater variability than the anatomy of the mitral valve. We start from the M mode, we start from the 2D and then to the 3D. But still, the tricuspid valve is 3D is always the aided value in the tricuspid valve in the tune of more than in 85% of patients. Now begin with the anatomy. There is a three leaflet usually. There is anterior, septal, and the posterior. There is a fibrous annulus, chordae tendineae, papillary muscle, RA myocardium, and RV myocardium. Now, if you do the cross section of the tricuspid valve, is located obliquely behind the aortic valve, which is absolutely at the center. The pulmonary valve is positioned anterior and superior and sidely to the left of the aortic valve. But how many leaflets does the tricuspid valve actually have? The valve consists usually of three leaflets named after their position, that is the anterior, posterior, or the septal. And if you can see the unfast view, then you can able to identify this is the posterior, this is the septal, and this is the anterior. And the normal valve area is 4 to 6 square centimeter. Anterior leaflet is also called anterosuperior, is the largest leaflet, and second largest is the septal, and the posterior leaflet is inferior or the marginal, and the most frequently the smallest of them, and often have scallops of the posterior valve. But really you can find out certain accessory leaflets, and they have been described. There is a 30 leaflet vary from 3 to 7, and these extra leaflets are called accessory leaflets. Accessory leaflets are very common in tricuspid valve. Coming to the subvalvular apparatus, now is the variability of the papillary muscle is a normal characteristics of the tricuspid valve. Number is varied from 2 to 9, but usually 2 to 3 papillary muscle can be seen or discerned in echocardiography. The anterior, which is the most prominent and which is often bifid or trifid, and septal papillary muscle is the least prominent and sometimes even may be absent. This papillary muscle you can see are connected by the moderator band, which can be best seen in the apical fourth chamber view. You can see in the fourth chamber view, and this is a normal anatomical structure. And the septomarginal trabecula carrying the part of the right bundle of the conduction system to the anterior papillary muscle should not be confused with the right ventricular mass. So this is very important. So any tethering of the tricuspid valve causing the dilatation of the tricuspid annulus, and both congenital and the acquired tethering of the tricuspid valve leaflet will result in impaired mobility, incomplete coaptation, and the apical displacement of the regurgitant jet origin. Now, while echocardiogram, the end-first view is the best, but what are the four more important view we do practice is the parasternal right ventricular inflow view, parasternal short axis view, apical fourth chamber view, and the subcostal view. The leaflet ID should be ideally be done from the end-first view of the valve. And that can be done only by the three-dimensional echocardiography or only in transthoracic echocardiography by two-dimensional echo from the modified subcostal view and only the ventricular perspective. So in a nutshell, if you do the basal short axis view, you can either see the posterior anterior leaflet here in the anterior or septal leaflet. Nothing is fixed. If you do a little change of angulation, it could be either anterior or septal, or it could be either anterior or posterior, because there are the three leaflets. Now in the right ventricular inflow view, you will get the septal leaflet or the posterior leaflet. And same thing in the apical view, either you get the septal leaflet here and the anterior and the posterior leaflet. by 2D or by 3D. So TT examination uses mainly the 4 imaging window that I've already described, but none of these windows can image all the leaflets of the tricuspid valve simultaneously. The transthoracic 2D, transthoracic 3D, and the esophageal 3D, you will find there is a definite dissonation of the tricuspid valve very clearly. So this is a 2D pictures. You can see that this is tricuspid valve. You can see here is you can see the transthoracic 3D, and this is the transesophageal 3D. Of course, the transesophageal 3D will give the better pictures in this. So if you want to do the en-face view, this is the ventricular view. You can see the tricuspid valve, anterior, posterior, and the septal. This is the anterior, and this is the posterior, and this is the septal. And this is the atrial view, where you can see this is the anterior, this is the posterior, the septal. And this view is most important in the en-face view in the evaluation of the tricuspid valve. Of course, if you do the longitudinal cut prints of the data set, allow the assessment of even the leaflet motion and the anatomy of the subvalvular release, where you can see the chordae clearly with anterior papillary emissions and the moderator band. Certain things you can, even the 3D, you can very clearly see. See, this is the septal. First one is the septal prolapse. Here you can see the vegetation in the infective endocarditis. Here you can see the tricuspid valve prolapse, and here you can see the entangled of the pacing wear within the tricuspid valve. Here also you can see the large vegetation in the posterior leaflet. You can see the large vegetation in the posterior leaflet. Here is, you can see the tricuspid valve orifice is totally fixed, as you see in the carcinoid. And there is a thickened tricuspid valve with the tricuspid stenosis, as we see in the rheumatic. And this is a prosthetic tricuspid valve with multiple vegetation. So these are the things you can see in the 3D. Of course, you can be advanced 3D printing, where you can give a clear image of the tricuspid valve to a surgeon also. This thing is called. So the role of TT is important. What is the important role of TT in assessing the severity of the tear and the right ventricular systolic pressure, as the images are obtained in a conscious patient with a normal resting hemodynamics. So baseline TT studies should also use to elucidate the etiology of the tear, measure the size of the right-sided chambers and the IVC, and assess the RV systolic function, and characterize any associated left-sided disease. So a technically adequate and complete TT examination may be difficult to perform in such patient, as we know in the COPD intubation and the post-cardiac surgery patient. So those are the patients we have to resort to the transesophageal view. There are the 4 more important view in the mid-esophageal level. Either it is the mid-esophageal 4-chamber view, where you can guess same thing, or the mid-esophageal right inflow view, or mid-esophageal modified bicable view, where you get the anterior and the posterior, or is the transgastric short axis view, and the transgastric right basal view, or the deep transgastric right ventricular view, to get the proper anatomy of the tricuspid valve. So this is a routine view of the transesophageal echo. You can see the anatomy and the tricuspid regurgitation very fairly. Now, after delineating the anatomy, this most important is the mechanism of the tricuspid regurgitation. This is the primary or secondary. See, secondary or the functional tear, where the TV annular dilatation, RV dilatation, or the papillary muscle dysfunction, where valve is absolutely normal, is absolutely 80 to 85% of patient. Whereas the primary or organic tear is constitute 15 to 30% patient is the intrinsic abnormality of the valve apparatus. So if you take the 70 to 80% of the functional tear, the commonest cause are chronic P, RV ischemia, left-sided valve disease, atrial fibrillation, or left to right side. Now, when you evaluate the tricuspid valve, one thing is very important to recognize, that tricuspid valve is a saddle shape structure, where there is a high points of these are the area and these are the low points. So normal, these has to be, I'll show in the 3D picture in the better way. So normal tricuspid valve diameter in adult is 28 plus minus 5 millimeter, and the significant tricuspid annular dilatation is defined by a diastolic diameter of more than 21 millimeter per square meter, or more than 35 when somebody is telling more than 40. So this is actually the subtle strip structure, and you can see the superior point and the inferior point. The low points are high points, and this is of ellipsoid shape. Now, what is the importance of the tricuspid annulus? Because this is very, very important. If you know this sticker, is if you do the MV repair only an MV repair with the TB repair, you can find the grade 3 to grade 4 tear persists in 34% of patients, if you will, and mortality is high. And if you do the MV and TB repair, mortality is very low. Should measurement of the tricuspid only performed using the 2D echocardiography? Yes. TA size measured during 2D echocardiography should be interpreted with caution because it is underestimated by 2D TE or 3D TE. So you should measure, and it should be substantiated by either by TE or by 3D. That's why is the role for 3D echocardiography. You know, there is a better approximation of the septal and the lateral dimension and allows measurement of the also the anterior posterior dimension. And if you do the short axis dimension, then long axis dimension, also the RV focus dimension, and it will give a clear idea of the tricuspid annulus in the printing also. Now, what are the pathology involved in the TB? TB can be affected by many conditions, where I already told you there is maybe primary regurgitation. These include the rheumatic, myxomatous, or carcinoid disease. Even in Epstein anomaly, is pacemaker dependent and or any device wear dependent. And functional tear is by far the most prevalent in includes 75% of patients. And it is the cause of these, you know, the left heart disease, in particular resulting in pulmonary hypertension, or any other cause of pulmonary hypertension, then myocardial disease, pulmonary embolism, even the atrial fibrillation with the dilatation of the right atrium can give rise to it. When the functional tear encountered during cardiac surgery is that due to valve disease and dysfunction of the left side of the heart. Small degree of tear is common, and that is usually central and a thin central jet. Say, here is the basic difference. So when you evaluate the mitral valve and the tricuspid valve, these valves is a different valve orifice, different subvalvular apparatus, and the different ventricle. But here TR and MR we are assessing in the similar ways, and that's why there is a paradox. So the functional tear is a tricuspid annulus dilatation, may be a more reliable indicator of TB pathology than tricuspid regurgitation. So whenever you assess the tricuspid valve, tricuspid annulus is a must. Whether it is a mild or moderate regurgitation, it is a moderate or severe regurgitation is less important than tricuspid annulus, because there is a good correlation between the tricuspid annular diameter and the TA regurgitant volume. The annulus is dilated if it measures more than 40 millimeter or 21 millimeter per square meter in transthoracic echocardiography, or in the surgeons usually do if they measure intraoperatively if it is more than 70 millimeter. So relevant abnormality of the tricuspid valve is that one is annulus diameter, then is the coaptation height, that is the tenting, that is if it is more than 8 millimeter, then RV abnormality of the RV, that is RV endastolic area more than 20 square centimeter, or the eccentricity index more than 2. And you do the RV dysfunction either by TAPSE or the systolic peak of the tissue velocity. One thing is very important is that the tricuspid, when the T dilates, tricuspid annular, it mostly along the RV free wall. Septum portion of the tricuspid is relatively fixed. Another important thing is that when you measure the tricuspid annulus, you have to take the inspiratory variability. So if you took the variability is near about 4 millimeter between the inspiration and expiration, so you must take the average of that. And when the tricuspid blood dilates, it flattened, not like in a saddle sept. So when it's happened, worsening tear, the annulus become larger, rounder, and flatter, and giving rise to tenting. So you must measure the annular dilatation and the tethering of the tenting. This tenting can indicate severity of the valve dysfunction. If you see tenting height is 3.3 millimeter gives rise to mild tear, here you say tenting height is 8.8, though the annulus area is same. So mechanism of tricuspid tear is a highly dependent on annular dilatation, with significant tear occurring only in 40% of the dilatation, whereas it is in 75% dilatation in case of mitral valve studies. That is, TB leaks earlier than the mitral valve. Now, reading of the tricuspid valve we already know, but two important points I must highlight. This is the most important one. That is the EROA. If it is less than 0.2 is mild, is more than 0.4 is severe, in between is the moderate. And R regurgitated volume, if it is less than 30 is mild, more than 50 is severe, moderate is 30 to 44. So this is, I can show you, this is a mild regurgitation, and you can find out this is a moderate tricuspid regurgitation and this is a severe tricuspid regurgitation. So this is the table view. There is a guidelines where you TA dilated is more than 40 millimeter in apical port chamber view. You have to do something. There is a guidelines is there. This sheet I'm talking. The mechanism of tricuspid regurgitation, where there is a functional tricuspid regurgitation, you measure all these parameters. So sort of time. One thing is that if you can 3D even, you can measure the TB tenting volume. If tenting volume, you can measure the tenting volume, that can be proper for evaluation. So what is the new direction is the evaluation of the functional TR is a more comprehensive approach there. So TR severity is the annular diameter and the leaflet coaptation mode. See, in mild case it is normal, whereas in the moderate case is age to age, and in stage 3, in the severe tier, it is absence, that is the leaflet coaptation mode, and for that the treatment depends. Now, in the iatrogenic tricuspid regurgitation, there is ever increasing prevalence of device places across the TB, such as pacemaker or defibrillator wires, can result in a degree of iatrogenic tear. And the relative complications are infective endocarditis. And these can happen after the patient, that can worsen the tear in observed in the post-CBD. See, this is an ICD inside an echo. There is nothing, there is a very little tear, and after 8 days, you can post-ICD, you can see the severe tear. And there is a pacemaker dependent tear also because of the lead impingement. So this is a pacemaker lead adherence, and there is a severe tear. And you can see is that there is a pacemaker lead is impacted in the tricuspid valve, and there is a severe tear. And this another thing after tear is the tricuspid stenosis. As the TB is the largest of the cardiac valve, significant TS is uncommon. Causes include rheumatoid and carcinoid heart disease. In addition, there is certain congenital heart disease like congenital tricuspid congenital stenosis or Epstein anomaly, tricuspid atresia, and other atrioventricular anomalies are also there. When you call this a significant tricuspid stenosis, see, you see qualitative, the right atrium is enlarged, severely enlarged, IVC is dilated, and the mean pressure gradient is more than 5 millimeter of mercury with a pH of less than 190 and the valve variable is less than 1. So I'll give an example, 25-year-old lady. This is a rheumatic mitral stenosis, you can see, with a moderate regurgitation. But if you see it very carefully, there is a tricuspid valve, there is a moderate regurgitation, and there is a flow convergence in the tricuspid area. And now if you see, this is, if you see the tricuspid valve is also
sir, only 2 minutes left, sir.
Okay, I just pass to the within 2 minutes. So you can see this, the tricuspid stenosis is a gradient of about 7 mmHg. So it's basically rheumatic mitral and tricuspid valve venosis. Here is a 1-year-old female infant, is a cyanosed baby. You can find out that there is a severe tricuspid stenosis and regurgitation. You can see the gradient of near about 14 mmHg in a 1-year-old boy, and there is a severe regurgitation. And in addition, there is also severe pulmonary stenosis. So it's a congenital combined tricuspid and pulmonary valve stenosis with moderate tricuspid regurgitation. Another 1-year-old baby presenting with the cyanosis, you can say this is a classical tricuspid atresia, where there is a VSD, where there is nothing, no flow is going into the inside. This is a case of really classical carcinoid disease, where you can see this tricuspid valve is totally fixed and is not opening and closing at all. And you can see there is nothing is flowing at all. And there is a severe tear. And another important part of the tricuspid valve has to be certain is located slightly closer to the apex. And if you measure this tricuspid valve attachment and
Excuse me, sir. Sir, 2 minutes left, so please start wrapping up.
Okay. So within 2 minutes I'll finish. So 1 minute I'll take. So there is a 8 millimeter difference, more than 8, there is an Epstein. So I'll show you in a rapid sun. This is a classical Epstein, and we can see the coaptation failure is here, and here is another curve with a non-compaction of the LV with the Epstein, and this is a 14-year-old girl. Again, there is a Epstein with rhabdomyoma, and there is another case of Epstein's with accessory mitral valve tissue. There is a very, very rare entity with yeah. And last case is the blunt chest trauma, where you can see this is a young boy had a history of injury 5 years back, and now they come to the symptomatic with a severe avulse, totally avulse. You can see the tricuspid valve from the papillary muscle, and same thing you can see in the 3D, and completely avulse and the placement. And lastly, the endocarditis, you can see the lead endocarditis are not out of this there. And so these are the different, this is a classical patient of the lead endocarditis, which was treated by medical management capsofungin, and this patient is improved. And that's why we saw the case. And this lead where is nothing is there. So summarize this: tricuspid valve function is a complex and depends on the size and function of the RV, RA, papillary muscle, leaflets, and chordae. Echocardiography is the method of choice to assess the TB function. Grading of the TB dysfunction is difficult due to a lack of reproducible parameters and reliable normal values. Assessment of TB function must therefore integrate all available clinical, technical information. Thank you.